The final item of business today is the members' business debate on motion number 9430 in the name of Nanette Millen on self-management of anticoagulation therapy. This debate will be concluded without any questions being put, and I would be grateful if those members who wish to speak in the debate could press the request to speak buttons now. I call on Nanette Millen to open the debate. 7 minutes, please.
Thank you, Deputy Presiding Officer. I'm sure we all know that to ensure the efficacy and safety of anticoagulant therapy, usually given orally as warfarin, regular monitoring is essential to ensure its effect stays within the therapeutic range, with the dosage adjusted according to the time it takes for a blood sample to clot. Because serious complications can occur if warfarin is poorly controlled, it's vitally important for patient welfare that the clotting time is checked frequently. And of course, traditionally, this has been done via hospital-based anticoagulant clinics. I first brought the issues of self-monitoring and self-management of anticoagulation therapy to the Chamber in 2010, because it appeared to me to be a cost-effective and beneficial way of enabling appropriate patients to be partners in their care, in line with government policy of encouraging self-monitoring and self-managing of long-term conditions, where that can be done appropriately and safely. At that time, Scotland lagged behind England and the rest of Europe, and this remains the situation today, with only 1% of patients on warfarin in Scotland self-managing their treatment, compared with 2% across the UK as a whole. Approximately 740 people in Scotland out of 25,000 in the UK are self-monitoring, with 70,000 people in Germany doing the same. NHS boards in Scotland generally do not provide support for self-monitoring or self-management of anticoagulation therapy. In NHS Greater Glasgow and Clyde, for example, only 40 adults, or 0.25% of the 16,000 patients on such treatment are doing so, whereas there's very good provision in York Hill for paediatric patients to self-manage. Unfortunately, as children in that area who can self-manage reach the age of transition to adult services, they have to return their monitors and go back to clinic attendance for treatment. In fact, only 3 health boards in Scotland have protocols for self-management of transitional patients. In my own region, NHS Tayside actively discourages patient self-monitoring, or PSM, and I'm told has even refused support where it was recommended to a patient by a consultant cardiologist. And NHS Grampian as yet gives no formal support, with the development of a protocol for self-monitoring being delayed due to a lack of enthusiasm for it from the various parties that need to be involved. There is, however, growing support for a change, and there are pockets of best practice in Scotland. A good example is Largs Medical Group, which is actively supporting 13 people to self-test through its active self-management service. And increasingly, there are drivers for change. Sign Guideline 129 on antithrombotics states that self-monitoring and self-dosing is safe and effective and can be considered for some patients. The Royal College of Physicians also encourages the use of self-management, stating that anticoagulation control may be improved by near-patient testing and encouraging patients in their own care. Patient education should be supported at every stage. NHS Scotland's 2020 vision for the NHS emphasises a focus on prevention, anticipation and supporting self-management, with the person at the centre of all decision-making. And finally, NICE draft guidance recommends self-monitoring for people on long-term anticoagulation therapy. The final report by NICE on self-testing systems is due to be published in July, with the expectation that self-testing will be increasingly supported in England and Wales, which could let Scotland slip even further behind. Unfortunately, the greatest resistance to self-testing for those who wish it seems to come from GPs and clinicians, according to the Anticoagulation Self-Monitoring Alliance. This was brought out in a roundtable discussion last year on the potential for self-monitoring of anticoagulation, attended by senior clinicians and patient groups, which resulted in 4 recommendations. 1. Sign Guideline 129 should be supported. 2. A review of the uptake of appropriate technology in Scotland compared with England and the rest of Europe should be undertaken. 3. A learning needs assessment for clinicians, GPs and other healthcare professionals should be carried out. And finally, 4. Consideration should be given to setting up a national service delivery model for anticoagulation to encourage health boards to promote self-management to appropriate patients. With regard to cost effectiveness, studies carried out by the NHS in Mid Yorkshire and health economists in the University of York showed that the NHS in Scotland could be saved around £600,000 in a year from the prevention of strokes, resulting from the improved control of anticoagulation achieved by self-monitoring patients. Furthermore, all the patients who took part in the Mid-Yorkshire study agreed that self-testing had been beneficial and would recommend it to others. In her response to my earlier debate, the then Health Secretary Nicola Sturgeon was somewhat lukewarm about self-management of anticoagulation, based on earlier clinical advice and on the fact that newer anticoagulant agents might replace warfarin. However, warfarin is still the treatment of choice for many patients, and expert advice is changing. Indeed, looking at replies from the current Health Secretary to some recent parliamentary questions from my colleague Richard Lyle, the Scottish Government is now taking account of SIGN Guideline 129. However, with still less than a 1% rate of self-monitoring in Scotland, something doesn't add up. The response from the Government to another question from Richard Lyle about what support is available to patients in transition from paediatric to adult services was that local protocols for the delivery of anticoagulation management vary across Scotland, but are in line with SIGN Guideline 129. At the time of transition, ongoing warfarin management, including self-testing, would be agreed as part of the overall plan of health care, clearly not generally the case. So understandably, it's been put to me that there's a significant difference between the answers given to Richard Lyle and the reality on the ground, where little or nothing appears to be happening by way of implementation. I'd welcome the Minister's comments on this in his summing up, because the Government needs to do more to ensure that patients are given the option to self-manage, rather than just to say that this is the case. So I'll conclude, Presiding Officer, as I did in my 2010 speech, because it's still relevant today, by urging the Government to look closely at how anticoagulant therapy is managed and to consider investigating the potential for increasing self-testing and self-management with a view to rolling it out across health boards to suitable patients, thus saving the NHS money and improving the quality of care for the large and increasing number of people in Scotland who need long-term anticoagulation therapy. Thank you.
Many thanks. And turn to the open debate. I call Aileen MacLeod to be followed by Jackie Bailey.
Thank you, Presiding Officer. I'm very pleased to have the opportunity to speak in this debate and want to begin by thanking Nanette Milne for securing debating time this evening. Now, warfarin therapy is, of course, vital to lowering the risk of strokes, heart attacks and other serious problems associated with clots forming in the bloodstream and possibly thereafter travelling through it to cause serious damage to major organs. However, we need to also be aware that while warfarin is a vital drug in the right amounts, it is vitally important to get the right balance right. And as my colleague Nanette Milne has observed, creating the circumstances where more people are able to manage their condition is very much in line with the Scottish Government's 2020 vision for NHS services.
Ms MacLeod, could you turn your microphone round slightly? Thank you. In
reading the background material for tonight's debate, I asked myself why what is being advocated is not in fact being more widely done now. And clearly, however, the key test that must be applied to every possible new development is the extent to which it is safe and effective. Certainly self-testing and self-management are standard practice for other long-term conditions. And I've often used the example in this chamber of the telemedicine diabetes clinic at the Galloway Community Hospital in Stranraer, which uses DiSend technology, specialist nurses and secure video conferencing to relieve patients of a very long round trip to see their consultant, and which gives them back flexibility into their day-to-day lives. And I can certainly see at face value the benefits of similar approaches to blood testing for warfarin prescribing. And in addition, there is evidence which supports the clinical effectiveness of both near-patient testing and self-testing. And as is so often the case, it may well be that a mixture of approaches is the most effective. Now, I note from the information that has been circulated to members that NHS Dumfries and Galloway, although it doesn't have a patient self-monitoring protocol, now advises that it will look to support patient self-monitoring going forward, which I certainly welcome, given the distances that some patients in the region have to travel to access healthcare. And in that regard, I also want to mention, Presiding Officer, the work which the Digital Health Institute is doing on the detection of atrial fibrillation using a device which can be used by a patient in their own home and which can in fact be purchased right now on Amazon. Atrial fibrillation is an important factor in identifying patients who are likely to benefit from the use of anticoagulant drugs. So detection of atrial fibrillation in the first place and the subsequent use of anticoagulants are very much related. Indeed, Presiding Officer, in my view, this debate highlights questions which are crucial to the way we will need to deliver healthcare in the future, where technology is likely to enable patients to take a far more active role in managing long-term conditions, in particular with the advice and supervision of health professionals. And of course, central to all such developments throughout must be the certainty that a testing, monitoring or treatment method is done safely and appropriately, and that appropriate education and training are also provided, as well as there being recognition that what works well for one patient may not always be appropriate for someone else. So in closing, Presiding Officer, we've heard examples this evening of patients for whom self-testing is clearly the right approach and for whom it is working well. For example, my colleague Nanette Millen mentioned the Largs Medical Group as one example of best practice, where for patients it was found that the biggest benefit by far was the flexibility of being able to test when they want, and they should be supported to do that. And in fact, the current guidance from Health Improvement Scotland recognises there will be patients in just those situations. So I look forward to hearing the Minister's views and await with interest the final report by NICE that is due to be published in July on the effectiveness of self-testing. And can I thank again my colleague Nanette Millen for bringing forward tonight's debate on what is a key issue in enabling people to be in charge of their own blood testing and monitoring.
Many thanks. Jackie Bailey.
Thank you, Presiding Officer, and can I start by also congratulating Nanette Millen on securing the debate this evening and for a thoughtful contribution. I would simply observe to the Minister that clearly Nanette Millen has persistence in driving change in this area, having had a debate on this issue before, and I've no doubt will return to this unless improvements are made. I'm very conscious, Presiding Officer, that we're talking about 1.25 million patients in the UK receiving anticoagulation therapy and patients requiring this therapy increasing by as much as 10 to 20%. It's estimated that of that number, there are 74,000 patients in Scotland who self-manage. So we're talking about a tiny fraction, 740 people, because it's only 1% of that total. Now, when you compare that to England, where the total number is 2%, there's approximately 25,000 people self-managing. If you look at Germany, the number rises to 70,000, and we're finding that self-testing is increasingly supported in England and Wales, and the danger is, in that context, that Scotland will fall behind even further. Aileen MacLeod rightly drew our attention to ensuring that it would be a treatment that was safe and effective. But clearly, if numbers are increasing in England and Wales, they have judged it to be safe and effective there for those patients. But it does appear that NHS boards generally don't provide for support for self-monitoring in this area, despite the fact that increasing numbers perhaps would benefit from it. Nanette Millen quite rightly pointed out that there are only 3 health boards in Scotland that have protocols for self-management. We should congratulate them for actually doing work in this area, but clearly there is a need to do more if we are to provide that opportunity for the population across Scotland. There is, however, quite a lot of success in training young people to self-monitor and to self-manage their anticoagulation therapy, but disappointingly no support for them when they move to adult clinics. And that question of transition from paediatric to adult services has been highlighted in a number of briefings. It does seem genuinely counterproductive that support for self-management comes to an end when they move to adult services, with many of them forced to attend anticoagulation clinics for testing, because having been in control and being able to manage their condition, they then lose that empowerment and cede control to others. So I would hope that we can look at this seriously. Now, I know that results from a Cochrane review suggested that self-monitoring or self-management can improve the quality of anticoagulant therapy, but it's not for every patient, and I recognise that. For some patients, it's not feasible. So we do require to identify and educate suitable patients. But I do think there is such an opportunity here to do more and to do it safely and effectively. The results are good. Nanette touched on some of them, but let me rehearse some of them again. 80% of poorly controlled patients moved into a well-controlled category after starting self-management. That, if anything, convinces me we need to do more. But equally, when you look at the improvement that results to patients in monetary terms, across the UK, it would prevent 500 strokes, save the NHS a minimum of £6 million, approximately 600,000 of that in Scotland. Other costings and other results suggest that for the 6,354 patients self-managing in NHS Scotland over 5 years, comparing it to standard care, you would avoid strokes and embolisms for 360 of them, avoid deaths for 186, and total cost savings would be quite extraordinary. You're talking almost 3 million of the 11 million current cost. So I would recommend this to the Minister, particularly when you consider that the cost for clinics reduces from almost 7 million to £500,000, and the test strips for prevention are a mere £67 for 1 year. So it makes sense. It's good for budgets, which should interest us all. It's good for patients because we're providing them with power and control. And of course, the Scottish Government's policy direction is about self-management. So why not with anticoagulation therapy? Thank you, Presiding Officer.
Thank you very much. And I ask Michael Matheson to respond to the debate. Minister, 7 minutes or so.
Thank you, Presiding Officer. And can I, like others, congratulate Nanette Millen in securing time for what has been a relatively short debate here this evening. Members will be aware that we have set out in our quality strategy in 2010 our clear commitment to make sure that patients receive safe, effective and person-centred care for every person every time they make use of our NHS. And as part of that commitment, we have supported people with long-term conditions to be active in their care. Our 2020 strategy and our quality strategy are complemented by our self-management strategy, Go On Yourself, which was written by people with long-term conditions themselves and adopted by the Scottish Government back in 2008. Since adoption, we have provided some £11.75 million through the Self-Management Fund to support people to manage their long-term conditions in the community. However, in addressing this particular debate tonight, I think we have to address some of the assumptions which have been set out within the motion, which I think may be slightly confused. Firstly, I think it's important to recognise that there is a difference between self-testing and self-management. They are not the same thing. Secondly, self-testing by warfarin patients is not the best option for the majority of patients in this particular group, who are elderly and may have cognitive impairments. Now, in Scotland, around 80,000 people are currently prescribed warfarin for the treatment of conditions such as irregular heartbeat, deep vein thrombosis, and for the management of mechanical heart devices. Making the blood clot less easily for these patients prevents blood clots forming and leading to strokes, heart attacks and pulmonary embolisms. But taking too much warfarin, of course, can cause death and disability due to internal bleeding, especially in the brain. Therefore, getting the right balance is absolutely vital for each of these patients, but it's also a challenge. Now, addressing some of the points that Nanette Millen raised and that Jackie Bailey has also made reference to, as are set out within the motion, it suggests that there has been a lack of progress in self-testing and self-monitoring compared to England and other parts of Europe. I'm not entirely sure on what basis that has actually that conclusion has been drawn. The only source of data regarding England that we've been able to identify has been from the company that produces one of the branded testing kits and machines. And on a European basis, we have to be very careful in how we deal with comparisons, because the provision of primary care is fundamentally different across different countries in Europe. The motion also that Nanette Millen proposes suggests that paediatric patients or their parents are supported by the National Cardiac Service at York Hill, self-manage. This is not the case. They do, however, self-test and forward their self-test results to a qualified haematology nurse who prescribes the medicine dosage, which is sent to the patient by a secure text. Then, when they move on to the adult service, there is one meeting with the adult team, after which the same arrangement continues. The motion also suggests that there is evidence it's clear that self-management of anticoagulant therapy provides patients with better health outcomes. In fact, it's worth considering the NICE guidance on this matter, their draft standards in February of this year regarding self-testing, which suggests it is more clinically effective than the usual approach of taking blood, sending it off to a lab and advising the patient by phone of the dose they should take. That's in self-testing rather than on self-management. Now, I'll give way to the member, of course.
Annette Milne.
I absolutely accept that there's a difference between the two, and I made that very, very clear in my debate I had a few years back. But, I mean, I accept also what you said about the children from York Hill self-testing rather than self-managing. But why should these same children, when they transit from paediatric adult services, then hand back their monitor so they're no longer self-testing?
Well,
Minister.
I've mentioned that they have the interview after they move into the adult service, and then they continue with the arrangements that were already in place. So I think there's an issue about some of the information that members may have been provided around the way in which services are actually delivered in this particular area. Now, some members may also be aware of the paper which was sponsored by one of the suppliers of self-testing technology, the York study. However, like the NICE study as well, the York paper is based on assumptions, including the average age of those on warfarin. The model assumes that the average age is 65 years. However, in Scotland, 77% of those on warfarin are older than this, and 28% are older than 75. These are important factors that need to be taken into consideration in any self-testing or self-management process that's introduced. There's also been a suggestion that Nanette Millen made, and that is that we should have a national service across the country. Again, I'm not persuaded that that's the approach to take, because I'm sure she'll recognise that boards have a responsibility to have local protocols in place for the delivery of services and to make use of the signed guidelines in this particular area, and to allow them to adapt that to their own individual local circumstances. That, to me, is a much more appropriate way in which to take this type of issue forward. Members will also be aware that we have also made significant investment in our patient safety programme in Scotland, which has been extended to primary care, which pays particular attention to adopting best practice in how we can systematically make prescribing of warfarin safer. And this has already been adopted in 8 of our boards in NHS Ayrshire and Arn, Borders, Dumfries and Galloway, Fife, Forth Valley, Highland and Lothian and Grampian. And Nanette Millen also made reference to the experience with the GP practice in Largs. It is worth keeping in mind that the GP practice that was highlighted in that particular pilot had a significant level of resource provided to it for the purpose of it. In fact, it had 1 GP, 3 practice nurses, 2 healthcare assistants and an administrator in their anticoagulant team. Now, that's a model which simply would not be sustainable in being rolled out across the country. So, Presiding Officer, I hope members recognise that this is an area where we do understand that there are changes taking place, and we are keen to make sure that patients who are receiving anticoagulant medication in Scotland receive the best possible care. But the method and approach that we take in Scotland should be one which is safe and effective and appropriate to the circumstances for each individual patient.
Thank you, Minister. And that concludes Nanette Millen's debate on self-management of anticoagulation therapy. And I now close this meeting of Parliament.